When would you consider a stem cell transplant?
So the stem cell transplant is based on disease risk. There's a number of ways we assess disease risk. The first two ones that were published a number of years back were the DIP score, which is the Dynamic International Prognostic System score, or the DIPS plus, which basically is the DIPS, and then you add to it a few other clinical features. This symptom score is based largely on, things that we can see without even a bone marrow biopsy. So things like symptoms, age, number of white blood cells, and whether somebody has anemia, and then the number of something called blasts, which is very immature white blood cells. The DIPS plus takes into account low platelets, need for transfusions, and chromosome abnormalities, which is the only test among that needs to be in from a bone marrow biopsy. Now, these were created prior to Jakafi being commercially available. So we have to take a little bit of a grain of salt with those because of the fact that Jakafi probably has changed how long people can live with this disease. Now, the more recently, they've tried to account for these other molecular changes. So when we take the genetic landscape of these diseases, we have the known driver mutation, so the JAK2 mutation, which I've talked about, also calreticulin and MPL. These three mutations all affect that one pathway, the JAK-STAT pathway. So they all affect the pathway that drives the disease. And they are known to be kind of mutually exclusive and definitely contribute to the formation of the disease. Some of these other mutations are called somatic mutations. They can be checked by things like next generation sequencing or, genetic analysis. There's a number of different names that people use for this testing, but we look for mutations that are present. And these mutations, number one, can sometimes tell us risk. So there's certain mutations that are high risk. Other times they can actually give us other opportunities for therapy, especially if the disease progresses. But these mutations are important to know for risk stratification. For example, if somebody has a DIP score that is maybe not super high risk, but then they have one of these mutations, we know that probably makes their disease a little bit more aggressive. And that's when we think about transplant, is when we know that the disease probably has an average life. When somebody gets to the point in their disease where we estimate their life expectancy is around 5 years, recognizing that we're not very good at this, that's the time point when we start to think about transplant. But the timing of transplant is something that's extremely difficult and a very personalized decision. It's something that it's really important to understand the disease risks, how we assess them, and the caveats of these disease risk assessments as we move forward planning on timing of transplant. And that's something that is again, a very, very important discussion to have at length with your physician. And I always recommend, there's quite a few of us out there who actually specialize in transplant for myelofibrosis. And having discussions with somebody who really understands the biology of the myelofibrosis is important because it's very different than a lot of the other diseases that are transplanted.